Welcome to Prostate Cancer Awareness, a call for action and care, an initiative of Voice of Healthcare and supported by CIPLA. Prostate cancer is a common cancer in men, originating in the prostate gland. It often grows slowly but can become aggressive. Early stages are typically asymptomatic, but advanced cases may cause urinary issues or pain. Screening via PSA test and imaging aids early detection. Treatment includes surgery, radiation, and hormone therapy. Early detection through regular screening, especially for men over 50 or with a family history, is crucial. We are privileged to have a distinguished panel of experts with us to discuss this important topic. Our speakers are Dr. Santoshi Nagaonkar, Director, Urology, Urological Oncology and Robotic Surgery, Sir H.N. Reliance Foundation Hospital and Research Center, Mumbai. Welcome, Dr. Santoshi.
Thank you. Thank you, Manisha.
Dr. Srivatsa N., Consultant, Uro-Oncology, Sri Shankara Cancer Hospital and Research Center, Bengaluru. Welcome, Dr. Srivatsa.
Thank you.
Dr. K.S. Kirushna Kumar, Senior Consultant and Head, Radiation Oncology, Head Oncology Services, Meenakshi Mission Hospital and Research Center, Madurai. Welcome, Dr. K.S.
Thank you.
Dr. K. Madan G., Advisor, Public Health Administration, NHSRC, Ministry of Health and Family Welfare, Government of India. Dr. Madan will be joining us shortly. I'm Dr. Manisha Khurana, and on behalf of Voice of Healthcare, I thank you all for joining us today. So this is a very crucial topic, and I want to start with the misconception. So my first question would be to Dr. Santoshi, that what are the most common misconceptions about prostate cancer and how can we address them effectively?
Yeah, firstly, let me thank CIPLA and the Voice of Health to give us this platform. And as we are discussing it, one of the most important topics, especially during this month of November, which is the Men's Health Month, I think it will be a good discussion amongst all the specialists. So there are several misconceptions about prostate cancer, and those misconceptions are not only amongst patients, but also amongst the doctors. The first misconception which we encounter quite often is that this is a cancer of old age. Although it is quite, like, by and large true, it's not completely correct, because we do see quite often patients who are in their young age, in their early 40s or even in late 30s with prostate cancer. And unfortunate to say that these cancers, they turn out to be more aggressive than old age prostate cancers. So age is not a huge criteria, but anybody who turns 50 should start getting their prostate checked. And anyone who has got a strong family history, they should start getting their prostate evaluated after they turn 40. The second misconception, which is very common amongst general practitioners, is, and it's a dictum which has been taught all along in our medical training, is you will die with prostate cancer and you will not die of prostate cancer. And we hear it very often. I have had so many doctors who have had raised PSA, and they are in their 70s, old generation. And when you try to talk to them about prostate cancer and evaluation about their PSA, they will say that, why do you want me to evaluate? We have always been told that prostate cancer it's non-progressive, it is non-fatal. And this is a big misconception. And I think we as our, we should start advocating as urologists, radiologists, medical oncologists about the importance of getting prostate evaluated. The other misconception which we always hear is that it's a cancer which is non-hereditary. But there is enough data to suggest now a substantial group of patients, they have got hereditary type of prostate cancer, just like breast cancer. So especially in early age, if the patient is under 65, 70, and if we try to screen their family members, mainly the first degree relative, there is a significant risk that other first degree relatives, they will have risk of prostate cancer. Again, at times patients come to us through health check. They don't have any urinary issues, and they feel that if they have no urine issues, no prostate issues, why should they get their prostate checked? Because they feel that unless until there are some symptoms because of prostate gland, such as frequency, urgency, or nocturia, they should not get their prostate evaluated. Again, that's a misconception because they feel that you have to wait until the symptoms are developed, but that's not true. As we know, if the prostate cancer is picked up in a health check setup, definitely it has got a high probability of being curable cancer. So you should not wait until the cancer shows its symptoms. And the last but not the least, which I see is once you hear the word about prostate cancer, you think that it's going to be a fatal disease, and most patients, they get scared as soon as they come to know that it's a cancer. But as we know, stage 1, stage 2, and even stage 3 cancers are potentially or highly curable with either monotherapy or multimodality therapy. So one should not actually shy away from going ahead with the treatment. Your healthcare worker, your specialist are there to guide you correctly. And these are the few misconceptions I can think of which we often encounter.
Right. So these misconceptions definitely guide us to get the early screening done. So I like to ask Dr. Srivatsa that how can there be a better communication and awareness around importance of early screening of prostate cancer?
Yeah, good evening, and thank you, Sipla and Voice of Healthcare, for this wonderful opportunity. A very relevant opportunity, I would say, like Dr. Santoshi mentioned. Again, I think Dr. Santoshi has highlighted some very important points about the misconceptions and myths of prostate cancer. So, screening, I think, is probably the most powerful tool we have as on date to identify prostate cancer early, so that the patients can be treated appropriately and there can be very good outcomes, including potential cure in a large percentage of patients. I think training the healthcare providers, the general practitioners at the grassroots level is the key, for enhancing the awareness of screening. Uh, the general practitioners can encourage men who are aged 50 or more, or men with family history of prostate or breast cancers, to get themselves screened. The second thing I would say is, targeted education programs where, like Dr. Santoshi mentioned, patients at risk, that is, men with a family history of prostate or breast cancers, can be picked up and can be educated about the potential increase in risk in them of prostate cancer and encourage them to go through early screening programs. The third thing is public health campaigns like this, what we are doing right now, where we talk more and more about prostate cancer and how easy it is to screen for early prostate cancer, and then encourage men to come on board to get themselves screened. The last would be the accessibility and ease with which a man can be screened. Most of the metro cities have access to screening programs with master health checkups, but these master health checkups are difficult to be achieved in tier 2, tier 3 cities or in the rural background. And if a governmental policy can be established for screening of prostate cancer, which is very easy, a simple blood test and a simple clinical examination, then this I think would go a long way in identifying a lot more patients with early prostate cancer.
Right. And since there is a strong family history also, which guides us that there must be some genetic factors. So my next question would be to Dr. Krishna, that what role do genetics and family history play in prostate cancer risk, and how can individuals be encouraged to assess their personal risk?
Yeah, thank you very much, Voice of Health and Sipla, for giving me this opportunity. And as Srivatsa already told, it is family history which is very important. If they have a breast cancer themselves, then they can have some genetic mutations there. It can be done. And BRCA1 and 2, which is there, can also be checked. These are some of the genetic studies which we can do. And as the other speaker also told, at an young age, we get prostate cancer because of genetic alterations. When such things happen and BRCA2 is already there, we tend to have a more aggressive disease, and these patients fail much more earlier than the patients who are at a later age group. So genetic testing is a part of it, and we can have a Lynch syndrome along with that, when they can have a pancreatic cancer and they can have ovarian cancer and other things associated with that. Then they tend to have a genetic alteration. Both the germline mutation and somatic mutations can be there, and such genetic testing and counseling will help the patient help us to detect much more earlier.
Right. So my next question would be to Dr. Santoshi, that how can primary care providers and specialists collaborate to streamline prostate care diagnosis and treatment?
Yeah, so this is a very important aspect of the entire evaluation and therapeutic tree, which we as healthcare, we have to have a very strong hold of it. Just to give you a perspective, like in Western world, if you see prostate cancer patient, if you have 10 prostate cancer patients coming to your office every day, at least 80% of them will have an early prostate cancer, as against 20% which may be advanced or metastatic cancer. And this proportion has been exactly reversed in our country, almost more or less. So, and this is all because of the poor screening program, what we have. So that is the importance of having a very good collaboration between the primary healthcare, which is the general practitioner or the family physician, and the specialist. So most of the general practitioners, they are well aware about prostate cancer. So awareness is one important part which is spread across the general practitioners. And they're well aware how to screen these patients, what basic tests have to be advised. Just a PSA, urine routine, if required ultrasound. And post that, if there is any abnormality found, then the patient is referred on to the specialist. Now, that collaboration has got a strong hold, because if patients are screened through this screening program, and if early cancer is picked up, then obviously the outcome is going to be extremely good. So the first thing is that we have to improve our screening program. Then there has to be a joint consultation which needs to be incorporated. If the primary health care person is extremely connected with the patient, they have got a family ties, then I think it helps in communicating with the patient as well about what are the outcomes of diagnosing prostate cancer in early stage, late stage, and what treatment modalities can be offered, because the input from the primary health physician will be important as well. As we all know, all these patients, they have to be offered customized treatment rather than giving them a blanket treatment. So not all patients are going to qualify for surgery or radiation or hormone therapy. So we have to customize this treatment. And if we have a good communication between the primary healthcare, the specialist, maybe medical oncologist, radiation oncologist, then it helps. Part of multidisciplinary approach is very important. So all in all, I think it is a joint collaboration between the primary healthcare provider, the specialist, and then multidisciplinary approach. All three um, routes are important for supporting the tree of managing any cancer for that matter.
Right. I think Dr. Madan has joined. Welcome, Dr. Madan.
Hello. Sorry,
That's
sorry,
okay.
I got stuck up in the traffic because. Okay, sorry for joining late. No issues. Please.
Welcome, sir. So I think I would start with you only. So my question would be to you that, sir, what advancements in diagnostic tools or technologies are making early detection of prostate cancer more effective? We have been talking about early detection and its importance. So could you guide us, sir?
Yes, definitely. Why not? Because if you look at the way things are moving in the public sector, as well as in the diagnostics field, of late, uh, uh, the serum PSA levels have been advocated as early markers for identifying whether the patient is having a predisposing factors for prostate cancer or not. That kind of thing is that. If you look at the number of tests which we are trying to bring in into our public system, uh, uh, more or less that would be helping us in aiding it right from the community health centers where this marker for prostate cancer that would be screened. But essentially if you look at the after post covid, we have been investing into the health infrastructure, especially the diagnostic facilities. In the diagnostic facilities you see the public health lab, integrated public health lab, there's battery of tests which would be available, including the screening for PSA. Besides that, at the lower level, the other aspect is at the block level, you are having a block public health unit, in which, in case somebody is suspected to have this prostate cancer, he would be referred and screening would be done for that. But one of the important thing which we need to understand that this prostate cancer is highly treatable, and the 5-year survival rate is good, provided it is detected early. But the main focus of our screening program is detecting the oral cancer, the lung cancers, and there is little awareness about very little awareness of that this cancer also needs to be identified. But en masse, in the structure which we are having, so we usually screen based on the symptoms that whether the person needs to be referred to a place or not. So that kind of advanced approaches are there. Besides that, in the diagnostic sphere, apart from this tool, there's a lot of R&D going on in seeing that how we can easily detect. But whatever advancements happens, it needs to translate into a scale. So for having this scale, we need to increase our awareness activities. As we are already on that, and we are already doing this. We see that how this awareness activity increases and the screening for this prostate cancer happens. The only effective tool is screening for prostate cancer, and how with the advancement of technologies and other things, how we take it to the next level. That's the important work needs to be done. I think that's work in progress.
Right. Right, sir. So next, I would like to ask about lifestyle factors and my question would be to Dr. Srivatsa that how do lifestyle factors such as diet and exercise influence prostate cancer prevention and management?
Yeah. So I would like to use this opportunity to highlight that prostate cancer, apart from having a genetic tendency or a hereditary tendency, is largely a lifestyle disease. Uh, 2 decades ago, we were seeing much less incidence of prostate cancer than what we see today, especially in our country. And largely, we can attribute this kind of uprise in the incidence to, alteration in the lifestyle. Diet, especially, carries a key significance in development of prostate cancer. We have found that ultra processed foods, packed foods, foods with preservatives. These are the kind of consumption of these kind of foods can actually enhance the risk of prostate cancer. Consumption of excess of red meat, consumption of excess alcohol, consumption of tobacco in any form have also been attributed to development of prostate cancer. So we would be probably better off, sticking to our native diets, which have gone through years and years of, the genetic thrifting, and most of us can handle the native diets much better without increasing the risk of prostate cancer. The second critical element in lifestyle is obesity. Obesity has been directly related to the increase in the incidence of prostate cancer, and hence, one key factor that can be utilized in a public health, campaign or public health awareness program is to, enhance physical activity so that most people can maintain a good or an ideal BMI or ideal body weight, which will help reduce the risk of prostate cancer. So not only is it hereditarily transmitted, lifestyle plays a very crucial role in development of prostate cancer.
Right, right, sir. So my next question would be to Dr. Krishna, that does prostate cancer disease or its treatment have impact on fertility?
Yes, it depends. Actually, what we are looking at is, depending on the, as earlier told, we are looking at two things. One is surgery at an early stage, and other one is radiation at an, we can divide the prostate person according to the risk factors. So some patients will fit in for surgery, and some patients will fit in for radiations. And sometimes some patients will have to look at, hormonal therapy. That is androgen deprivation therapy is what we call it. So surgery, I think a radical prostatectomy or a robotic prostatectomy would be the choice in some patients. I think surgeons are there in the panel. They'll be able to explain much about it rather than me. And radiation therapy, as such, we are today we have higher techniques, so we are limiting much more things to prostate itself, and the side effects are much lessened. So fertility is not a major issue there. But whereas it comes to hormonal treatment, we sometimes have to do a bilateral orchidectomy. So testis removal is a part of a treatment in that particular scenario. I think surgeons can tell better on these things, I think. Srivatsa or Satish Nagaonkar.
So if you want to add any comment, or you'll be happy to know.
Yeah, I think Sir has already comprehensively covered it. The one key factor is, at least luckily as of now, we are seeing a large proportion of prostate cancers in relatively middle-aged and elder men, not in relatively younger men who are still desirous of, fertility. So that one advantage we have as on date, but wherever fertility preservation has to be done or potency preservation has to be done, modern techniques of treatment can definitely help achieve that.
Right, sir. So now I would like to ask that are there any mental block barriers? So my next question would be to Dr. Santoshi, that what are the barriers men face in assessing prostate cancer care, and how can these be reduced?
So, so the first mental barrier most men they have is going to a doctor itself, because the genetic makeup of most men is that we are like rock solid, especially when we are in our 20s and 30s. We feel that no disease can catch us. We are really strong. And going to a doctor itself is a big ask for many people, many men. And even if there is any minor issue or intermediate issue, they will try to get it sorted out at their own level with simple medications, over-the-counter medications. The biggest problem we are facing now is the Google doctor. And everybody wants to just go on to Google or ChatGPT, find out what is the treatment modality. So it's becoming harder and harder for getting these new generation people to get convinced and seek medical opinion. Now, when patients come for prostate examination, then obviously, if they are at a GP practice, then probably the GP is going to ask for a PSA test and urine test, which they'll be happy with, unless until they have a phobia for getting their blood collected by a phlebotomist. But otherwise, that goes through well. But the moment they enter into a urologist practice, the physical examination is going to be a challenge. And if they have had a bad experience with their physical examination, which is the digital rectal examination, as just for the general population, I need to tell the physical prostate examination is done from the back passage, the rectum. It is not that bad. It is not uncomfortable. It is just a moment of like 25, 30 seconds of discomfort, which they may experience. But that gives us a lot of information. And that is one thing which can dissuade these patients from coming to the urologist and get their prostate evaluated. Again, many times they have some misconceptions, like as soon as they get to a urologist, there will be a battery of investigation which will be asked, and there will be a lot of expense which will be involved. But mind you, most of the times we urologists are very diligent, and we will not really ask for any unnecessary investigation. But having said that, if there is any possibility of even small possibility of suspicion about prostate cancer, then there are certain investigations which we have to suggest, such as MRI on prostate gland, and if required, even a biopsy. So I think if we be realistic, if we increase the awareness, educate these patients, counsel them well, that is very important part of any consultation, then I think their fear will be released, and they should be able to face these various investigations in a diligent manner.
Right. So, from counseling to leveraging social media, my next question would be for Dr. Madan, that how can we leverage social media and digital platforms to amplify prostate cancer awareness?
So this is important because my previous speaker has emphasized upon the awareness activities. Okay, so before starting with the awareness thing, one is the awareness regarding this, which is currently very low. But if you look at the structure which we are having in the public sector, we are having around 2 lakh 10,000 health facilities. The peripheral most facility being the Ayushman Arogya Mandirs, which has the teleconsultation facilities. And the teleconsultation means that means doctor to doctor consultation usually happens, and the prescription is generated then and there only. So that's one way. So that's one way we are trying to see that how we can improve the screening of this screening for prostate cancer. In any suspect is there, so always they are consulted with the higher hub, that means at the CSC or the district hospital. They are consulted, and based on the consultation, either their samples are referred or they are referred to the civil the higher center, that is community health center or the district hospital. That's one way. That means if somebody is suspected to having that. Second thing, for addressing the awareness related issues, we do have NPNCT program, that is National Program for Non-Communicable Disease, which talks about cancer screening, including stroke and everything. In that, current focus is on oral cancer, cervical cancer, and this. We can improve the gamut of this. So the training modules are there. Currently, the training of the frontline workers and the volunteers. So it's going on. That means we are creating a cadre of people who can impart education to the community through interpersonal means, so that the awareness and utilization of the services we are providing to the centers increases. First is bringing the people to the fold, then only they can be referred to the higher centers and provided treatment. So how to bring them into our treatment fold, that's one of the challenges which we are facing, and we try to address it. One is bringing the patients to our centers. In case they are having some symptoms, they have been referred to the higher center and consulted with the higher center to teleconsultation. That program is known as e-Sanjeevani, and I am very proud to report that more than 30 crore consultations have happened in the last the last 2 years. So that kind of thing is happening. That means people are now getting used to seeking treatment at the higher center. After that, the patient is shifted to the higher centers, and that kind of referral mechanism do exist. The second thing is we are having a volunteers, the health volunteers in every village. You would be having a ASHA volunteer, accredited social health activist, and they have been trained for screening based on the symptoms, based on checklist. And anybody having that kind of thing, so they would be brought to the Aishman Arogya Mandir, and from there through teleconsulting other things, they would be either connected with the medical officer at the primary health center or referred to the district hospital or the medical college. Invariably, all the districts are now getting converted to medical colleges. That's a good thing which is happening, so that the tertiary care level specialist service is also made available. Besides that, after screening, they have a choice because PMJ is another program. If a poor who falls in that bracket, they have a choice of seeking care in the private and the government sector. That's another thing. Coming back to the raising the awareness activity, one of the things which we are targeting the beneficiary is to interpersonal communication. That means we do have a 1 million plus health volunteers who are working there, supplemented with around 30,000 health workers who are skilled workers, and a battery of around, I am not citing numbers, but things are happening. And if your numbers are there, at least even if 10% starts working, it's a common perception that nothing happens in the government sector. It's not that the case. If you look at the footfall in the government and the private sector, the footfall is more or less equal. But if you talk about the cost of care in the private and the government sector, so it is skewed towards the private sector. So footfall same, but the expenditure happens more in the private sector. That's why people say that the care happens. No, it's not like that. If you look at the structure, we do have a presence right up to a village level. Though it may not be of a standard of a tier one city, but the structure is there. A qualified person is there. A BSc nursing person is there, and they have been enabled with the e-Sanjeevani platform so that they can consult back to a medical officer and they can get guidance. And some tie-up with medical colleges, Tata Institute, and other agencies are also being made, so that in case when the person is screened based on symptoms, he is referred to the higher center. From there, they are picked up based on the markers, and they are put to treatment. That's a different aspect which is happening. The treatment program that is in the treatment also, hub and spoke models and other things are happening. Coming back to the second aspect of the awareness things, we do support conferences and other things for raising awareness right in the provider space also. One is awareness for the community. What we are doing is we are focusing on IPC and other activities. For for the audience in the urban sector, we are targeting through the electronic media. But the audience in the rural sector, we are targeting interpersonal communication in a very big way. So that's another. But apart from this, we are trying to build the capacities of the providers as well. That means the doctors and others, we are trying to build in some online training modules for them. That's a self-learning modules besides having a virtual sessions for them. And if somebody want to apply for some courses, that kind of thing also be made. So this is the second aspect. Third aspect is building capacities of the institutions as well. We're trying to build in because, as I mentioned, that invariably all the district hospitals would be having a medical college. That means the tertiary care facilities would invariably be reaching the medical colleges. So the loop is there. The awareness activities, you are having plenty of people who are there who would be doing through interpersonal communication. They would be bringing the people to the system, and if they are brought to the system, if in case some higher consultation is required, they would be connected to the higher centers. After that, we are having a tie-up with different models are there. It's not universal. Different models have evolved, and you see that how that model evolves. And some of the states they have been able to screen a lot of population. I can just say that some of the states, to begin with, they have screened the population for cervical cancer based on symptoms. 90% of the women they have been screened in some of the states. But this is catching up because this is based because of the lot of emphasis efforts which have been put in on the awareness activity, that through only the interpersonal communication that is now yielding results. So that means, to summarize again, interpersonal communication, use of the local channels, use of the social media uh, in your urban areas. So that kind of setup. Similarly, we are having a setup in the urban areas also. So in nutshell, you see that what kind of concentrated efforts which we are making. Uh, we have to take help of others also. Many people are working in different silos. We see that how we bring together so that the awareness activities which we are making, that starts building and people come forward and start getting tested. In fact, you will remember that globally the second leading cause of cancer among the elderly men. And if it is detected early, then the 5-year survival rate is more than 90%. That means you see the key and the predisposing factor, as my previous speakers have mentioned, the genetic predisposition and the family history is there. Is that we can always screen these people based on the awareness level and other things and bring to our fold and provide treatment. Thank you.
Right. So addressing the issue at the grassroots level by interpersonal relationship, by counseling, by electronic media, by training, I fully agree, sir. That is what is needed. So my next question would be to Dr. Srivatsa, that what are the emerging treatment options for prostate cancer and helping patients and families make informed decisions?
Yeah. So, prostate cancer is a very amenable cancer to treatment, meaning to say that, especially in early stages, uh, the treatment opportunities are excellent and with a very high chance of cure. Like Dr. Santoshi said in the very beginning, even in stage 3, patients can be, planned to receive appropriate multimodality therapy and, be cured from the cancer. In the past, doing the surgery or delivering radiotherapy to the prostate cancer used to be a challenge because prostate is a very deep-seated organ deep inside the pelvis, and access to this organ was very difficult. But in the last 2 decades, we have adopted minimal invasive surgeries like the robotic surgery or the laparoscopic surgery, which has transformed the way we manage prostate cancer patients. With these minimally invasive techniques, uh, the the complexity of the surgery is reduced, the outcomes are excellent, and the oncological results, that is the chances or probability of cancer cure, is also pretty high. Similarly, in the arena of radiotherapy, there has been a substantial advancement in the radiation techniques that are adopted and the newer technologies that have been adopted, where the prostate cancer can be precisely treated by and significant reduction in adverse effects or side effects can be achieved. Of late, with screening, we are also identifying very early disease limited to the prostate with a very small volume of cancer being present in the patients who can be offered what are known as focal therapies like the cryotherapy or the brachytherapy, and the cancer can be cured with a very high probability in these patients. It might be interesting for you to know that close to about 18 to 20% of patients with very early prostate cancer who have a low risk disease can also be monitored by what we call as an active surveillance without having to undergo any treatment. We have now data for about 15 years, a long term follow up of several thousand men who have been monitored with very low volume, low risk prostate cancer, who have done equally well in comparison to if they were being treated with either surgery or radiotherapy. Of course, I would like to emphasize that active surveillance or no treatment observation strategy is not for all prostate cancer patients. It is for highly selected patients with very low volume, low risk cancer, and with constant monitoring, these patients may not require any treatment at all. Even in advanced stages of disease, though we may not be able to cure prostate cancer, the treatment opportunities for long-term disease control are excellent, with minimal treatments like hormone therapies and mild chemotherapies. Patients with advanced prostate cancers can also be managed for several years, provided their treatment is planned appropriately by a team of care providers.
That is excellent, sir. So my next question would be to Dr. Santoshi, that what specific measures can be taken to support caregivers of prostate cancer patients?
I think we did address this question earlier. So anyway, I'll reiterate, like basically for caregivers, I think, so there are two things which are extremely important. The first one is education, and second is awareness. Unless until the caregivers have been made like aware of and educated about the prostate cancer in the right way, we will not be able to progress further in reducing the mortality from prostate cancer, reducing the morbidity from prostate cancer. So there are various platforms we can use to improve this facility. If there is the physical connection is missing, definitely, as previous speakers have already said, telemedicine is an excellent facility where the primary caregiver can connect with the specialist through a telemedicine portal, and you would be able to consult the patient and give further instructions in regards to how to evaluate these patients of suspected prostate cancer, or if there is any abnormality with their PSA or any of the urological issues. So the first thing would be, as I said, having a better communication between the primary health caregiver and the specialist. The second thing is a joint consultation, which I mentioned earlier. Having a joint consultation is extremely helpful, especially those patients who are not relying or not putting their faith completely in their specialist in the first row. Third thing will be a multidisciplinary meeting, and the outcome of multidisciplinary meeting has to be conveyed to the primary caregiver so that they are well aware and they are in the loop about the patient's treatment modality. And when we are deciding about a treatment modality, as I mentioned earlier, we have to approach a customized treatment rather than a blanket treatment. And in order to do so, we have to take these primary caregivers in confidence before we can kind of transfer that treatment to the patient, because the primary caregiver or the family physician will know the patient's family background, their financial background, their social background, and all that has to be taken into consideration before we can communicate that to the patient. So I think, as I mentioned earlier, education and awareness is extremely important in delivering a good treatment outcome.
Right. So my next question would be to Dr. Krishna, that since we are talking about awareness a lot, so I would definitely like to ask that what is the difference between urban and a rural sector population, how much they are aware, and what steps can be taken to bridge the gap,
Yeah.
if there is any.
Yeah, good. Definitely there is a lot because I come from a tier 2 city. The basic difference between both lies in the treatment aspect in the prostate cancer and also the presentation also. So what really happens, I'll put you some examples through. So prostate generally occurs at an age of around 55 or 16 at an average it comes. But here in an urban sector, what happens is they're a little bit educated and they understand the disease. They probably read up and come when they come to the physician. So they are much more aware that the prostate cancer can be cured, and if treated properly, as they said, it is a multimodal treatment, and with the tumor board discussion, it can be done well. But whereas compared to the rural setup, what happens is generally around 55-60, the patient will take a decision. It is an attenders who take the decision, and attenders may not be willing to treat the patient, or in some sense the patient themselves, because I'm already lived, I'm 55-60 or 70, what is the need to treat? That is what the logic comes. The moment they say it is cancer, they get the fear of death. So when you say prostate cancer to the age of 65 or 60 and above, they really don't want to treat. That is really itself takes a lot of counseling is needed to convince them for treatment. This is one aspect in the early prostate cancer. But when it comes to metastatic disease, like where they say that the prostate is already spread to bones, for example, at the same age group, if you take, other disease other than prostate, other sites have a poor prognosis. Poor prognosis, the results are much more lesser compared to prostate. In a prostate patient who already has a bone disease, the results are much better. Even with the stage 4 disease or a metastatic disease, the patient could live longer even for 5 years or 10 years. But it is not curable, but it is treatable definitely. And they can be living little longer life compared to other site of diseases. So that awareness is not there even among the non-oncology physicians or even the treating physician. So that is what primary caregiver and we have a good discussion. It will be much more better, and if we raise that awareness, many of the patients can live longer. And that is simple treatment. Just drugs are enough, or just injections are enough. Not chemotherapy, just hormonal manipulation will be enough for them to treat. It's really not that expensive, and it is really not troubling the patient like any other chemotherapy. They can just put on hormonal manipulation and they do well for even 5 to 10 years. And on average, they live more than 3 years. So that awareness also has to be there. So there is a lot of difference between urban and rural, because the literacy rate is less here and the education is less here. But in urban, those are there already. So it's much more easier to, when we talk to the patient, they much more understand better and they get convinced easier. But for us, whereas they don't get convinced, there are a lot of patients who go back and then come back after 1.5 years with the disease which is aggressive, and then they come back to us. That's what I would like to say.
Right. And I think I would definitely like to ask Dr. Srivatsa also that what are his points on that how caregivers or healthcare workers, can be made aware of the steps to be taken for prostate cancer. Dr. Srivatsa, please.
Yeah. I think Dr. Santoshi has already elucidated what the caregivers have to be aware about and things. I just wanted to highlight 2 points or 2 strategies that we have started in our institution since the last 4 years. We recognize that caregivers play a very crucial role in management of any cancer patient, because it's very overwhelming for a caregiver. Having to take care of their near and dear ones, see them suffering and support them through it, and then also be coping with the financial burden of treatment, so on and so forth. We found out that a lot of caregivers were becoming ill themselves during this process. So we started, a healthcare program for the caregivers. So we encourage caregivers to get themselves tested every once in 6 months regarding their own health, other than the prostate, that is, other than PSA. So we look at the other parameters, the metabolic parameters, hypertension, so on and so forth. So we are now extending this as a extended service to all caregivers who would wish to come and get themselves tested for a nominal fee. This is just to encourage and keep the caregiver spirit up. The second thing what we have done for the caregivers is to provide what is known as respite care. So we have a volunteer program where, because caregivers have to constantly be taking care of the people who are sick at home, they will probably lose out on their personal time and social life. So we are now providing what is known as respite care, wherein one of our volunteers will pitch in for a brief period of time, like say for 5 hours, 6 hours. When the caregiver wants to take a break, go out and have a social engagement, or just simply even take a break. So this has been received very well in our hospital, and a lot of caregivers are utilizing these services. These are totally voluntary. We do not charge them for that, and we feel that this is a very small step of comfort that we can offer to the family which is already overburdened with the disease.
Right. And I think survivors play a very crucial role, and whatever they suggest, people will follow. And I would like to ask Dr. Madan that what role do survivors and patient advocates play in creating awareness and providing support to newly diagnosed individuals?
Thanks, Manisha. You asked it because I invariably would have mentioned this in my uh, other statements, which other questions which you would have asked. Because if you can't, because the survivors would be a great role models for the others to come forward and get the treatment done. The challenges of the cancer survivor are very, very different. you see how it is gaining and it is becoming a movement, because you see a survivor network which is evolving. The patient survivor networks are coming. They share their thoughts. They talk about the treatment modalities. And as a result, what happens if anybody is having some suspicion about the treatment modalities available, these patient support groups, they usually encourages the patient to come forward and take treatment. And it has to become a movement. It's still working in silos, scattered. Now we see that how another challenge which the organization like WOH, VOH can do is to bring all the silos together and have a patient support group so that they can help each other in raising the awareness about the treatment aspect, the challenges faced during the treatment, as well as motivating others to come forward and see that how the agony and other things which they have faced, they can usually help in bringing the people to the system, getting them seen, and seeking care at an appropriate time. So this is a movement which is catching up nowadays. And in coming days, you will be seeing a lot. But these patient support groups needs to be connected with the government system, because the scale. I have interacted with many of the patient support groups, but they are not aware what government is doing. They should be coming and working closely with government or like-minded others, uh, agency, philanthropic agencies or other agencies working in the field of cancer, so that the work which we are doing for the cancer patients and what efforts which we are making, they can at least add, they can share their insights into that, and they can enrich whatever understanding we are having about the awareness activities, because they are the sufferers, and they might have been detected at a later stage, or some of them might have been came into the fold in a very early stage. So they would be acting as a good models for bringing the patient into the system, raising awareness, as well as helping them in overcoming the treatment crisis and other things. So definitely in the coming days you will be hearing more, but we have to make it as a movement so that more and more people can join, and they can, and after joining this group they need to be connected with the government system or any other system, so that the scale and the volume which is anticipated, because by 2040 we would be having double the number of prostate cancers in the country. So a lot of things have to be done, and it is only possible when collectively we rope in the patient support groups, bring them into the government and the other people who are working in this area, and see that collectively, synergistically, how we can uh, complement each other in awareness about the cancers and cancer-related diseases.
Right. So my next question would be to Dr. Krishna, that is there any role of radiation therapy in treatment of prostate cancer?
Yes, the two things, like, in a much earlier stage, like, very high risk or very high risk prostate cancers. It is, I know some patients we do give surgery, some patients we do give radiation therapy. So it all depends on, multimodally we'll have to discuss with the uro-oncologist and then decide on what is best suited for the patient and decide. But what I would like to add here is radiation therapy has totally changed over the last decade. Earlier to that, it used to be having a lot of side effects, and it used to have a prolonged treatment of 30-35 days. It used to be there, and these facilities were not available in many of the centers across India. But today, with radiation therapy, there are a lot of newer techniques where we can confinedly treat the prostate and have very minimal side effects around. Like, bladder is closed to it, urinary bladder is closed to it, small intestine is closed to it, large intestine is closed to it. So these kind of side effects are going to be very less, because we can properly confine the treatment according to the area which we want to treat. But another biggest advantage which has come is what we used to treat at 35 days, today we are treating at only 20 days. And some of the indications we treat within 5 days. The patient finishes the entire treatment schedule within the 5 days and goes off, and with the lesser side effects. This is in the curative option. But there is another option where we do is in a palliative setting. Palliative settings is patient when comes with the disease, they have a lot of pain in the bones which they develop. So to relieve that pain, we need to give some amount of radiation to that site, where 10 days of radiation would help them relieve the pain totally. So two phases. One is at a curative option at an earlier stage, and the later option where the patient we can think about palliating the symptoms like pain, or sometimes the bone, vertebral body can have an pressure on the spinal cord and had some cord compression. There you can relieve the cord compression effects. We can relieve. There are two sites which we can give radiation therapy here.
Right. So, my last question would be for Dr. Santoshi that how can healthcare policies be improved to make prostate cancer screening and treatment more affordable and accessible?
Yeah, I think this is most important part, especially in Indian scenario. And we have got Dr. K. Madan Gopal as well around here so that he can give his insight. We can actually give some recommendations. I'm sure he's well aware of all these recommendations, but if we look at the worldwide nature of how the budgeting is done, then we'll see that stark difference between how the breast cancer is treated and how the prostate cancer is treated. There is a huge difference, and there is a huge gender bias here, unfortunately. So just to give you the US data, there is about the annual the budgeting which is done for breast cancer awareness is close to $500 million. And if you look at the prostate cancer awareness, it's half of that, $200 to $250 million. Now, I cannot extrapolate the same thing in India. India, there may be much more difference. It may be in tunes of $100 million for breast cancer, and for prostate cancer, it may not be even $5 million. So this difference has to, this gap is huge, and that has to change. We have to make more and more men aware about their prostate cancer. And it's not only the men, but even the women, they have to be made aware about their counterparts, that prostate cancer is equally important. It could be equally fatal, but at the same time, it may have a better chance of survival than breast cancer. The other thing is, because of the social differences with breast cancer, because it's a feminine organ predominantly, there is a lot of importance given to the breast cancer awareness as against prostate cancer, which is a hidden organ, and not many men would like to get their prostate examined by the specialist. It gets sidetracked. So we have to, again, coming back to, it boils down to increasing the awareness and making most people educated about the prostate cancer and how it can be easily diagnosed and can be treated, potentially curable disease. So we have to take the lawmakers on our side as well. We have to make them aware that yes, prostate cancer is a big healthcare burden, and it is going to increase in due course. As Dr. Madan Gopal said, in another 10 years' time, the incidence of prostate cancer is going to get doubled up. So we are going to see a sea of prostate cancer patients in the next few years' time. We also need to have good data collection. Currently, we are just relying on the data collection from the most of the cancer registries, which are placed in 6 or 7 different parts of India. But the patients who are going to nursing homes and private clinics, corporate hospitals, they get missed out. We don't have any data collection on that. Otherwise, if we have got a centralized data system somehow, then we'll have a good impact worldwide to see how these Indian cancers behave, because there is a fundamental difference between Asian prostate cancer and Western prostate cancer. And I'm sure most of the uro-oncologists and medical oncologists, as well as radiation oncologists, they will agree with me that there is a difference between treating Indian prostate cancer patient and Western prostate cancer patient. Last but not the least is tying up with the insurance companies. We still have a completely biased insurance system. So if you look at the Western world, their insurance companies, they will just charge you a premium, which is annual premium, maybe for individual or family, but they will cover the entire gamut of diseases. no questions asked, whether you're doing a robotic surgery, whether you're doing proton beam therapy or anything, no questions asked. But in India, we have got a lot of red tapes on insurance companies, and they are imposing it on patients. So the robotic surgery is not covered by most of the insurance companies. Certain radiation therapies are not covered. Certain medical drugs are not covered. So there has to be some uniformity in offering these therapies so that patients do not have to actually think about what kind of therapy they can go for, what is the best therapy they can go for. Let the job be decided between the patient and the caregiver rather than the insurance companies. So
I
all
think,
these factors,
yeah.
they need to be addressed, and we need to have the government agencies to step in and create this uniformity. That's what I have to say.
Yes, I fully agree. And I think this is a good sum up. And thank you all for joining us. And let's take the idea forward and drive a positive way. Thank you, everyone.
Thank you.
Thank you very much.
Thank you.